We are good to go, sir.
Yeah. Hi, everyone. Very good evening. I welcome you all to the Yashoda Hospitals Emergency Medicine Friday webinar series. Today, we have yet another interesting topic to discuss, that is thyrotoxicosis. Although not commonly seen, but very important diagnosis to pick up and treat. So today, we have with us Dr. Ahmed Mubashir, the consultant at Somajiguda Yashoda Emergency Department, is here with us. He will take forward from here. Dr. Mubashir, please take over.
Okay. Good evening, everyone. Am I audible?
Yeah.
Okay. So, good evening, everyone, to one and all. My name is Dr. Ahmed Mubashir, and I'm the ER consultant of Yashoda Somajiguda, Hyderabad. Okay. I am here to discuss about today's topic, thyrotoxicosis. It is one of the very life-threatening diagnoses which we usually don't see in our places. But yes, in the external Western countries, this is very much over there. So let's go with the presentation without wasting any of our time. Okay. Okay. So just going back once again to our basic before starting on to thyrotoxicosis, let's just revise our anatomy. Uh, this is our normal adult thyroid gland, which is highly vascular bilobar organ overlying the anterior trachea. The thyroid function is it secretes two iodinated hormones, T3 and T4. Only about 20% of the circulating T3 is directly secreted by the thyroid. The remainder is produced by peripheral conversion of T4, which is done in the peripheral tissues, T4 to the more biologically active form. Okay, so this is supplied by anatomy. If you remember our blood supply, it is supplied by superior thyroid artery, inferior thyroid artery, and followed by the nerve supply is by right recurrent laryngeal nerve and left recurrent laryngeal nerve. So just before going over to the main agenda, let's just have a revision of thyroid physiology. So I think you are all aware of thyroid metabolism, how it happens, and what are the feedback mechanism involved. So let's just start with everything. Go ahead with hypothalamus, from where the initiation happens, which goes pass on to pituitary gland. So the hypothalamus and pituitary in the brain control the normal secretions of thyroid hormones, which in turns control our ultimate metabolism. Okay, so this is how our physiology is like. Hypothalamus releases thyrotropin releasing hormone, which in turns acts over anterior pituitary. And then acting over anterior pituitary, we have thyroid stimulating hormone, which acts over thyroid gland. Now, this thyroid gland acts on T3 and T4, uh, through which uh, triiodothyronine and thyroxine hormones are released. Now, talking about these hormones, on an average, T4 is to T3, 10 is to 1 is the potency. T3 is 4 times more potent than T4. So biologically active once as I said, T4 is converted into T3, that is more biological active form. Now half-life of T4 is almost around 7 days. T3 it is around almost 1 day. So T3 is present 20%, which is, as I said, 20% released from thyroid, 80% from peripheral conversion. Now, what are the functions? Basically, what are these involved? What do these do? So it basically increases sympathetic activity, and followed by that, thyroid is so much regulated in our body that it controls our basal metabolic rate in such a way that everything is on the higher side. Like if you ask, ATP consumption is on the higher side. It starts with heat production, followed by lipolysis, followed by protein breakdown, followed by glycogenolysis. Then on upon that, we have gluconeogenesis, and then finally we have an ATP consumption. This is how increased metabolic rate happens, basal metabolic rate, in our hyperthyroidism patients. So just a brief description, how much are the normal levels? TSH is almost around 0.4 to 4.5. T3 is almost around 100 to 200 nanogram per deciliter. and T4 is around 5 to 11 mcg. Free T3, free T4 are also important. We need to keep up in our minds 2.3 to 4, followed by T4 is 8.5 to 15.5. This is like our basic physiology, which we have already done. Yeah, the same thing increases sympathetic activity, increases BMR at the ATP consumption, and followed by gluconeogenesis. So this is just a presentation how I have placed it. I mean, you guys can see how this thing is acting. Thyroglobulin is sensitized and discharged into the follicle lumen. From there, it is taken up over the Golgi apparatus and rough endoplasmic. Since then on, how the iodide comes in, trapping the active uptake of iodide, after which oxidation happens. And then later on, this iodine enters follicle lumen, where it is attached to tyrosine. So the same thyroid follicle, after attaching with tyrosine, it forms into DIT and MIT. So thyroglobulin collides, and then later on it forms into iodinated tyronases, which are linked together to form T3 and T4. So this combines with the lysosomes, and these are endocytosized, and followed by that lysosomal enzymes cleaves T4 and T3 from thyroglobulin. So this is how a normal functioning happens. And then followed by that, finally, T3 is released outside to the peripheral tissues, which is the highest metabolic rate, or you can say active form of thyroid hormone. So this is how the conversion happens of T4 to T3. You guys can, if you want, you can take a screenshot as well. Now coming up to our thyrotoxicosis. So basically, you all know that hypothyroidism is overproduction and increased circulation of thyroid hormones. Followed by that, we have, it is actually a specter of all the components of thyroid. So thyrotoxicosis, once again, it's a hypermetabolic condition which is happening due to elevated enzymes of T3 and T4. And lastly, thyrotoxicosis, which gets more severe form, is known as thyroid storm, which is like acute life-threatening form of severe thyrotoxicosis. Now, before going to severe thyrotoxicosis, let's just get back to our this thing. How does it happen and what are the causes for it? So we actually divide hyperthyroidism into two. Basically, it is primary hyperthyroidism and secondary hyperthyroidism. Primary hyperthyroidism is like excess production of thyroid hormones, followed by secondary hyperthyroidism. It is excess production of thyrotropin releasing hormone or TSH. So eventually, thyrotropin releasing hormone from hypothalamus, and or you can say TSH from uh, pituitary gland. Okay. So, what are the causes of hyperthyroidism? So, basically, first we start with primary hyperthyroidism. Causes for this are, one is grave disease, which is also known as toxic diffuse goiter. So, this is one of the most common presentations of hyperthyroidism. Almost around, it accounts about 85%, which you see grave disease. Next is toxic multinodular goiter. This is the most second common cause of hyperthyroidism. Followed by that, we have toxic nodular adenoma, in which we have just an enlarged thyroid gland, which contains a small rounded mass or nodules with overproduction of thyroid hormone. Followed by that, we have thyroiditis, which is once again simply inflammation of thyroid gland. And lastly, it is Hashimoto's thyroiditis. Now, Hashimoto's thyroiditis, once again, it is an autoimmune disease. Initially, gland is overactive, but typically it follows a state of hypothyroidism. So, initially in Hashimoto's thyroiditis, it tends to be hyperthyroidism, but eventually it lands up in a state of hypothyroidism. So, these are the causes of our primary hyperthyroidism. Now, next, secondary hyperthyroidism. It is like, once again, it involves thyrotropin secreting pituitary adenoma. So this is once again thyroid gland stimulated to produce hormones. Now, eventually, what are the external causes? So external causes, we have in a range of it. First, it is like non-thyroidal, and second, it is like drug-induced. Non-thyroidal, it could be ectopic thyroid tissue. So it is a rare form of mature teratoma, which has a thyroid tissue. So through this also we can have uh, hyperthyroidism. Followed by that, we have metastatic thyroid cancer, which is eventually production of extraglandular thyroid hormones. Now, coming over to drug-induced or iodine uptake, we have Jod-Basedow effect, because of which external causes, which is known. Second one is drug-induced amidron. So amidron accounts almost 37% of iodine, which may cause thyrotoxicosis or even may cause hypothyroidism. So it is involved in both hypo as well as hyperthyroidism. Se Followed by that, we have interferon alpha, or you can say involving even interleukin 2. Followed by that, we have thyrotoxicosis fasciitis, so which is accidental. And lastly, but not the least, is ingestion of meat containing beef thyroid tissue. So these are the external causes of our hyperthyroidism. So we have primary and secondary, followed by that external causes. So external causes are non-thyroid, followed by drug-induced. So drug-induced, mainly we have iodine, amidron, interferon alpha, followed by interleukin 2, and lastly thyrotoxicosis fasciatica. So now, how do we diagnose it? So basically, what are the samples you send for if you have a patient with hyperthyroidism? So how do you get the evaluation done, or how do you come to a diagnosis? So a main component of this is TSH level is the main factor. Followed by that, you have to send your blood levels, complete blood picture, serum electrolytes, all the other blood analysis samples you have to send. So once you get a TSH level, if it is high TSH, which is rarely seen, you have to go for measuring T4. And if at all, if it turns out to be high, then you can call it as secondary hyperthyroidism. So if it is a secondary hyperthyroidism, you have to go for an imaging for of pituitary gland. If it is a low TSH, so you have to go for measuring T4 level. If at all, if it is normal or within the range, where T4 is within the normal range, you have to check for free T3 level. If at all, if T3 level is within the normal state, we call it as subclinical hyperthyroidism. So once again, this is a resolving hyperthyroidism, and it can be because of even medications, or it can be secondary to pregnancy. If at all, if T3 levels are high, then it is ruled out as T3 toxicosis. This is if T4 levels are within the normal range. What if T4 levels are on the higher side? So once if T4 levels are on the higher side, we call it as primary hyperthyroidism. So primary hyperthyroidism, we have to analyze how it is, whether it is because of low thyroid uptake or is it because of high thyroid uptake. So now going over to low thyroid uptake, we have to measure thyroglobulin. So we have to send samples for thyroglobulin. If it is decreased, it could be because of exogenous hormone. If at all, if it is increased, you can say it as thyroiditis, iodide exposure, or extraglandular production. If the thyroid uptake is high, then we have to see whether it is diffuse or nodular. So if at all, if it is diffuse, we call it as Graves' disease. If it is nodular, and if it is on multiple areas, we term it as toxic multinodular goiter. Or if it is just only one hot area, we call it as toxic adenoma, like how we just classified in the primary hyperthyroidism back over here. Graves' disease, toxic multinodular goiter, toxic adenoma, thyroiditis. So the same goes over here. So this is how, like I tried to summarize in a flow chart way so that it is understood by everyone and it's easy. Okay. Yeah. Now, moving over to thyroid storm or the severe form of thyrotoxicosis, what are the precipitants? You basically, what actually triggers this thyroid storm. It is not just only because of the hormones, there is some underlying pathology involving. So what are the precipitants because of which this leads to happen? So first of all, it could be infection, it could be any trauma induction, or it could be because of secondary to some surgery. Secondly, it could be because of diabetic ketoacidosis or increased sugars where ketones are trace, or it could be HHS. Thirdly, you can involve some cardiac or pulmonary causes like thrombosis, myocardial infarction, or CVA or pulmonary embolism. So one of the precipitants form of thyroid is even iodine itself. So iodine even trigger the thyroid storm, followed by thyroid hormone ingestion, or if there is a sudden withdrawal of anti-thyroid drugs. So these all are the causative factors. So next factor what you can think about is even pregnancy where it can induce this or eclampsia. Followed by after these reasons, even it could be idiopathic where the percentage seems to be around 25%. There would be no cause, just a thyroid storm happens. So usually maximum of the times it happens with patients who are in severe infection, long-standing chronic infections, or the patients with DKA, or most of them, the second causative factor in the precipitants is iodine itself. So that could be one of the major factors. So these are the precipitants of our thyroid storm. So now, how do you diagnose it once we are over the condition that like, is it hyperthyroidism or is it subclinical hyperthyroidism or is it T3 toxicosis or is it hyperthyroidism in elderly? So this is just a brief table I have given so that people can understand once you analyzed your TSH, free T3 and free T4. So hyperthyroidism involves low TSH. So common factor for all the diagnosis of hyperthyroidism, TSH will be low. The only factor where it tends to depend upon is based on the levels of free T3 and free T4. So if TSH is low and if free T3 is high and free T4 is as well high, you call it as hyperthyroidism. If at all, if both the things are normal, so you can call it as subclinical hyperthyroidism. If at all, if it is T3 toxicosis and if it is low, so then over here, T4 is over the normal range, T3 is over the higher range. So we term it as T3 toxicosis. And followed by that, hyperthyroidism in elderly. Once again, T3 may be in a normal state, T4 will be on the higher side. So this is just a descriptive manner I have tabulated so that you all guys can understand and take a note of it. How do you, term it as whether it is subclinical or T3 toxicosis or hyperthyroidism? Okay. Now coming over to clinical features of hyperthyroidism. What are involved in the hyperthyroidism? So this is just a brief description I have placed so that you guys can understand how the things are happening in this. So usually the patient when they present to ER, they have like high intolerance. So it's like basically it's a systemic wise where you can take up this. I have just prescribed in this diagram how do you remember it. So basically they come down with complaints of excessive sweatings, intolerance to heat, followed by fine straight hair, or they term it they have high loss of hair, followed by bulging eyes, and then you have facial flushing, you have enlarged thyroid, you like graves, or followed by that when you come over to cardio system, you have tachycardia, systolic BP will be on the higher side, and then coming over to the peripheral ends, you can see fingers with clubbing, you can see the fingers with tremors, followed by over GI system, you have diarrhea, you have hyperactive bowel sounds, and then you can see a patient who takes a lot of food, but then he has significant weight loss, and then followed by that he have muscle wasting, and over to reproductive system in females you have amenorrhea, menstrual changes, and throughout these kind of patients they'll have generalized or localized edema. So these are mostly the common presentation to ER would be like tachycardia, severe flushing, followed by bulging of eyes and diarrhea. So this is how the patients present to us in your ER. Now, these are some of the signs where I have just managed to keep it off. So we call the patients with hyperthyroidism, they present with exophthalmos. So these are the signs. One is like Stelwag sign, we have Kocher sign, and we have Joffrey sign, we have Mobius sign, and we have Enroth sign. So these are all the things which are involved in our uh, clinical signs of hyperthyroidism. So this is one of the tests how you try to diagnose it off. So basically, when you try to palpate our thyroid gland, you perform this and you see a deviated trachea over to the same side where you try to push it off, the huge thyroid mass. So the trachea gets deviated to the same side. We call this as Kocher's test. I think you have all have learned all this in surgery. And then the other sign we have this as Berry sign, followed by that Pemberton sign. So now coming down to ER, once the patient lands up with you, how do you like once you finally get to these all these symptoms, we have a diagnostic criteria. But once again, this diagnostic criteria one lands up basically with the clinical findings and the scoring. It is once again non-specific, but during the people of Japan, they try to formulate it, and this is how we call it as Birch-Watt-Sky diagnostic scoring system. So our parameters basically depends upon first is temperature, followed by that CNS effects, followed by GI hepatic dysfunction, and then involving CVS system. Basically CVS system where we see only tachycardia, followed by that we try to rule out if there is any congestive heart failure. So all of these have their own scores. So whether AF is there or not, if AF is absent, we have a score of 0. If it is present, it is 10. And followed by that any precipitating event is there in the past. So all this tabulation and formulations, when you try to score it, if it is less than 25, it represents to have there is unlikely of any thyroid storm. If it is 25, between 25 to 44, if the score, then it is suggestive of some kind of impending storm is about to happen. And if the scoring is more than 45, then it is highly suggestive of thyroid storm. So trying to rely on this is not suitable, but then yeah, coming to a conclusion or approximation of your diagnosis will help you with that. And this is one of the very keen scoring systems which is used in hyperthyroidism. So basically temperature ranges from between 37.2 to 40, where you have a different scoring parameters. And CNS, which involves like if it is agitation, we consider it as a mild. And if it has any kind of delirium or psychosis, or if the patient is in a confused state, severe kind of lethargy, patient does not able to move anything. And the severe state is like if he has continuous seizures and seems to be in coma. So this is how we rule out for CNS effects, followed by even GI system involves if there are any diarrhea, nausea, vomiting, we term it as moderate. And if at all, if it is accompanying with jaundice, we term it as severe. So this is a broad spectrum scoring which helps you to approximate your diagnosis. So this is how you come to a final with your blood workup. Once you are done, TSH is low, free T3, T4 is high. Once you do a random blood sugar, which turns out to be hyperglycemia. So it is all because of secondary to glycogenolysis, because of which catecholamine mediated insulin antagonism is there. Followed by you witness a hypercalcemia. because of bone resorption. Then you have LFTs. Sometimes LFTs could be deranged. CBP mild, where the findings would be mild anemia and leukocytosis. Cholesterol levels tends to be over decreased side. Thyroglobulin low, infectious thyrotoxicosis, and then followed by USG Doppler, and then radioactive iodine decreased in thyroiditis. So this is how you tabulate your diagnosis. Okay. So coming over to management, once again, management involves once the patient starts, you start treating the patient and you identify with the clinical features or all the history taking, and whenever you come to a tabulation that how basically before going to, I'm sorry, I missed it off, but coming down to what are the differential diagnosis once you end up with the these kind of symptoms. So probably you can say our differentials would be like uh, first would be sepsis because of infection, then some kind of heat exhaustion because they even complained of heat, followed by heat strokes, some kind of delirium where coma is also involved, some kind of malignant hyperthermia because of the temperatures would be there, malignant neuroleptic syndrome as well, hypothalamic strokes, followed by pheochromocytoma, psychosis. So these are all your differential diagnosis before coming to hyperthyroidism. So one of them, once you try to regulate it off, all these kind of symptoms are also found in all these DDs. So over to the management part, we have basically the management is tabulated in a form that we have to go in 5 phases. First of all, it has to be supportive care. Second, it has to be inhibition of peripheral adrenergic effects. Thirdly, it has to be by inhibition of new thyroid hormone synthesis. Fourth, it is inhibition of thyroid hormone release, which has to be done at least 1 hour after inhibition of new thyroid hormone synthesis. Followed by that, preventing peripheral conversion of T4 to T3, which happens in the peripheral tissues. And followed by that, prevention of free thyroid hormones reabsorption. So this is how we try to manage a patient who presents with hyperthyroidism in our ER. And followed by that, once you are done with all these, simultaneously you have to rule out even the precipitating event. What is the precipitating event involved? Is it once again MI, or is it some kind of pulmonary thromboembolism, or is it some kind of sepsis? Is it some kind of decay? We need to rule out the precipitant event which has caused this or which has triggered this. Finally, you have to end up the patient your treatment with definitive therapy. So what is your definitive therapy? It could be radioactive iodine ablation or followed by surgery. So now let's just say the patient lands up and you start treating him. So basically you have to first comfort the patient with external cooling because he'll be having hyperthermia, followed by cooling blankets and antipyretics, which helps you resolve it. And if the patient is, once he starts sweating, diaphoresis is there, patient will land up in huge dehydration or glycogen depletion. So you can start off with IV fluids, and to support restore your glycogen, this thing, you can start off with 5% dextrose to replace your glycogen storage. Followed by that, the initial treatment would be like uh, first inhibition of peripheral adrenergic effects, because it is all simultaneously. Once you see hyperthyroidism, it is all because of the initiation of adrenergic effect system. Once you settle down the adrenergic effect system, everything simultaneously tends down. So first inhibition of peripheral adrenergic effects, you have to start with propranolol, beta blocker. So zero point 0.5 to 1 mg IV, followed by 1 to 2 mg every 15 minutes. And then later on, once this is done, 60 to 8 mg, 80 mg every 4 hours per orally. If at all, if you do not have propranolol, if you want a shorter conversion, you can take up esmolol as well, 250 to 500 mcg per kg IV. Followed by that, 50 to 100 mcg per kg per minute. So this is how the beta blockers help you in reducing the inhibition of peripheral adrenergic effects. Now, if at all, if the patient has landed up in failure, or if the patient has, I mean, like he is against beta blocker, then you can go ahead with Respirine. But again, you have to be very careful once you are giving Respirine, because it's better to avoid in heart failure or if the patient is in cardiac shock. Sometimes, even if Respirine is not there, you can even consider guanethidine. That is once again 30 to 40 milligrams. So this is how you initially inhibit peripheral adrenergic effects once the patient is in ER. Followed by that, once you are done with the second phase, your third phase would be like inhibition of new thyroid hormone synthesis, where you would have to go with methimazole, 20 mg. So every 6th hourly. But what if the patient is pregnant or if she is a lactating mother, then methimazole you cannot be giving, because it is, as per the Food and Drug Administration, it is categorized as category D. So you have to go with PTU or propyl thiuracil. So a loading dose of 500 to 1000 milligrams even per orally, followed by 250 grams every 4th hourly. So PTU in first trimester, if you come down, if you land up with hyperthyroidism, you can go ahead with PTU, not with methimazole, and followed by, once the patient comes into second trimester, then again you can give off methimazole because it is safe in second trimester. So this is inhibition of new thyroid hormone synthesis, followed by that inhibition of thyroid hormone itself. This has to be done after exactly 1 hour of your third step, like inhibition of new thyroid hormone synthesis. It needs to be done after 1 hour. So either it has to be by with Lugol's solution, or with potassium iodide, or with lithium carbonate. So once again, lithium is contraindicated in pregnant ladies. So, or even if breastfeeding. So you can go with potassium iodide or ipodate. So these are especially useful. Followed by that, preventing peripheral conversion. Now, how do you help stop the peripheral conversion, which is T4 to T3? This you can be doing by hydrocortisone, by giving off 300 to initially, followed by that 100 mg every 8th hourly. Or if you do not have hydrocortisone, you can go ahead with dexamethasone, 2 mg IV every 6th hourly. So followed by that, prevention of free thyroid hormone resorption, you have to give cholestyramine every 6th hourly, which is for the which the dosage is of almost around 4 grams. So this ultimately, stepwise, when you do it off, you tend to stabilize the patient. Followed by that, again, once you are doing this, you have to even simultaneously treat the precipitant. Whether it is MI, you have to treat your MI. Whether it is a DKA, start of DKA correction. Whether it is sepsis, you have to take blood cultures and start off IV antibiotics at the earliest. So this is how you try to resolve it, and followed by ending up helping the patient with definitive therapy. Now, what are the ATA guidelines, or what are the recommendations which have been now newly coming up? So, newly pregnant with grave disease with euthyroid status, it is like potential teratogenic. For you can say methimazole. Discontinue all antithyroid medication. Assess for 1 to 2 weeks. So high risk of thyrotoxicosis. If receiving methimazole, you can switch off to PTU at the earliest. Beyond 16 weeks, there is no such recommendation. You can continue with methimazole, because methimazole is considered to be potential teratogenic. Followed by that, radionuclide scintigraphy or radioactive iodine determination should not be performed in pregnancy. Once again, HCG mediated TSH separation is suspected to be there in early pregnancy. And once you are suspecting because of HCG, you need not treat it. You just rather stop all the antithyroid. You just need to monitor it. You need not start any antithyroid medications. And then you have iodine 131 for the lactating mothers. And if the patient is on breastfeeding, I mean, she's a breastfed mother, you have to discard for 3 to 4 days before resuming breastfeeding. You cannot just directly start off. And finally, the lowest effective doses of PTU should be given for lactating mothers, if at all, if it is indicated. But otherwise, if any HCG, once again, like transient HCG mediated, you need not start treating hyperthyroidism. Just wait and watch, and it is just a TSH suppression because of which this happens. So you need not start any anti-thyroid medications. So the guidelines which we have currently, or which are the latest ones, are a pregnant woman should never be denied indicated surgery, regardless of irrespective of any trimester. Elective surgery, if at all, if it is planned, it has to be postponed until after delivery. So within the delivery itself, you cannot go ahead with the elective surgery. You have to postpone it, followed by delivery itself. And then, if at all, if possible, non-urgent surgery should be performed in second trimester before preterm contractions and spontaneous abortions are less likely. So these are our guidelines for which we have to follow in pregnant ladies. So this is how the tableted form for a treatment of thyroid storm. Initially, we start with supportive care, followed by inhibition of peripheral adrenergic effects. Thirdly, we have inhibition of new thyroid hormone synthesis, followed by that inhibition of thyroid hormone release, and then preventing peripheral conversion, followed by that prevention of free thyroid hormones reabsorption, and simultaneously treat the precipitating event, and followed by definitive therapy. So the same way over here, I have written it off. So inhibiting peripheral conversion T4 to T3 hydrocortisone or dexamethasone, followed by prevention of free thyroid hormone reabsorption, cholestyramine 4G. So definitive or ultimate therapy for these patients would be like radioactive iodine ablation therapy, followed by surgery, and then ultimately treat the precipitating event, whether it is infection or MI or decay. So you have to be like, your treatment for the thyroid storm would be like this eventually. So as I said, inhibition of thyroid hormone synthesis, propylthiouracil, which is has to be given in the first trimester. But then once again, PTU has hepatic failures, but it is best suited for first trimester, followed by that methimazole 20 mg for second trimester and third trimester. And then inhibition of thyroid hormone release, you go with potassium iodide drops or Lugol solution or sodium iodide. Once again, lithium carbonate, again, it's contraindicated in pregnancy. So I just happened to have, I mean, like witnessed recently when we were going through, I witnessed to have a female who was recently underwent total thyroidectomy for Graves 2 disease 2 weeks ago. Followed by that presentation to ER was she was complaining of tingling and numbness in the fingers and around the mouth since few days and aggravated since today morning. So on arrival, she was hemodynamically stable. So you can see the sign how it was. What do you suspect? Anybody? So we term it as late post-surgical hypoparathyroidism, wherein which there was a parathyroid destruction during the removal, after which the patient landed up in hypocalcemia. So severe post-operative cases manifests as tetany. Basically, we have to treat with calcium and vitamin D supplements. So once again, all the DDs of thyroid storm, you have sepsis, you have heat stroke, malignant hyperthermia, you have hypothalamic stroke, you have pheochromocytoma. Sometimes even drugs can lead to it. similar symptoms like cocaine, amphetamine, ketamine. So what are the, as an ER, or once we are working as an ER physician in ER, we need to have some new updates as well. So new insight towards, recently there have been some news about acute non-thyroidal illness syndrome. So this is where you consider, this is come down when the patient has low T3 and elevated T3, which are inappropriately to be seen in some of the patients. So this happens because of increased inflammatory cytokines, which evidently play a role in derangement of iodine expresses, and because of which reactive oxygen species are released. So we have this kind of other presentations also in here. We term it as acute non-thyroidal illness syndrome. Followed by the latest trends are being focusing on minimally invasive subtotal thyroidectomy, embolization of thyroid arteries, followed by plasmapheresis, percutaneous ethanol injection into toxic nodule for a toxic nodular goiter, and supplementation of L-carnitine also helps in improving symptoms and may prevent bone loss. So these are the new recommendations which are coming into effect, and even the uh, surgical who are the consultants, they are considering these into consideration, these kind of options. So while going through, I also wanted to share you guys with where during COVID-19 we had this kind of scenario facing, like thyroid hormones level, just when they are elevated, they inform about the disease severity and mortality in COVID-19. So that was also a study done wherein there was no such perfect conclusive, but then people tend to be like, even if I mean in COVID-19 thyroid hormone levels were tend to be on the higher side. And followed by that, we have, like, biotin interference in assays, which helped in thyroid hormones, thyrotropin and thyroglobulin. This kind of study actually helped in reducing these hyperthyroidism, because once there were a few studies done on this where they have taken a daily dosage of 10 mg, which has shown to improve the uh, consequences for these kind of patients and reduce hyperthyroidism. So a daily dose of 10 mg was taken, for with specific assays of TSH, T4 and T3 and TG. So these were the simultaneous studies done, which are still not yet considered, but are still studying. So these are all the new trends which are happening for hyperthyroidism. Okay. So, yep.
Yeah, thank you, Ahmed Mubashir, for a lucid talk. And do we have any questions to take? I think no questions. Fine. So I have few questions. So can I go ahead?
Yeah, please.
Yeah. So now, how do you generally, what is the ideal time to send a thyroid profile? That's a common question that we get, right?
Yes. So whenever you have a suspect, when you see the patients landing up with multiple scenarios or multiple systemic effects, or you have the multiple systemic insults, like patient turns up with a tachycardia or severe sweating, or if at all if he has grow hair loss, and then patient comes down with eventually complaining of, I am having a significant weight loss. Followed by that, patient tends to have, when you do an when the patient enters into your ER, have a tachycardia. When you do an ECG, he presents with AFib. Followed by that, some kind of premature atrial contractions are there. So eventually, when all these multiple systemic insults are there, you eventually tend to send this blood investigations, suspecting some kind of, either it is hyperthyroidism.
Thank you. My question is, at what time do you send the sample?
Uh,
is there any ideal time to send a sample, or we can send randomly at any point of the day?
No. It is you have to send it early in the morning itself.
Yeah, because as we all know, it follows the circadian rhythms. So usually it has to be sent in the early morning hours to
Yes,
get an ideal result. And the
exactly.
next question I have was, how do you differentiate between hyperthyroid and thyrotoxicosis?
So hyperthyroid is, you can say, the initial form of, or you can say like initial raise of the thyroid hormones, wherein you have, which are released by the hypothalamus, TSH is raised. But thyrotoxicosis, it is the severe crisis, or it is a hyperimmune immediate metabolic state which tends to happen because of the increased, which is not being treated at an initial state and which has progressed to a further state.
Okay, fine. So now you receive a patient in emergency. So now we have a patient with high fever, tachycardia, probably AF is secondary to non-cardiac AF. Okay. So because of the infection, he might have had AF. So now how do you make a difference between sepsis versus thyrotoxicosis?
Okay, that's a very interesting one. So once the patient lands up, that's what, once the patient lands up, and then you tend to have this thing, when you tend to have these kind of vitals where you have tachycardia and where you have secondary to arterial fibrillation. So you have to, I mean, eventually first start ahead when you are suspecting with, if it is a hyperthyroidism, eventually you will have all the other multiple systemic involvement as well. The patient may even have diarrhea, the patient may even have some kind of high grade fevers. So yes, you have to go ahead with your intuition that if at all, if this patient has landed up in this state, so you may have to initially start with beta blocker treatment, and then eventually you can go ahead with the further simultaneously treating the precipitate cause.
Probably you say you should go by a clinical description because it's
Yes,
very difficult to differentiate between sepsis
yes,
and thyrotoxicosis, because essentially you'll have all the features that we have in thyrotoxicosis are there in sepsis as well.
it is very
Okay.
difficult. Even
Yeah,
similar to that, sometimes we have, I mean, like DKA patients, they never tend to say it up, like whether it is the precipitate. But later on, once you try to send off the thyroid profile and all, when you see TSH and T3, T4, then eventually you'll end up saying that, oh, okay, this is secondary to this and has happened this.
okay. Fine. Okay. Next, the final question I have is, you have a patient who is on amidron for arrhythmias generally. So now this fellow has come with atrial fibrillation. Okay.
Yep.
And now, how do you differentiate between suboptimal dose, or is it because the amidron is inhibiting the peripheral conversion and then causing thyrotoxicosis? How is it? How does it go?
Okay.
Because amidron is one of the precipitant cause for thyrotoxicosis.
Okay. So first of all, in such kind of scenarios, our history taking is very important, basically. So if the patient says he is already on amidron and because of which this presentation is there, then you have to strongly suspect it. Secondly, once you start even amidron, even after that, the treating scenario is not resembling out. I mean, the patient is not getting benefiting with that. Then you have to strongly suspect over there whether is it.
Okay, basically you should go by history and physical. That's what you say, physical
Yes.
examination. Okay, fine, thank you. Do we have any more questions? Don't think. I think we can conclude our session. Thank you for your active participation, and we're looking forward to see you in another Friday webinar series. Thank you.
Thank you, everyone.